it just pain down the foot, or does it go from the top down?
It goes all the way down.
When it goes down, does it go down the front, side, or back of the leg?
The back of the leg.
All right.
Yes, sir.
All right. Any weaknesses there all the time?
Not all the time, but if I overabsorb myself, I'm very weak on my left side. Yes, sir.
And what are you doing in terms of tobacco or vaping? Totally done.
Yes, sir.
All right.
Most definitely.
Lift this knee up with your hand. Was it vaping or cigarettes?
Cigarettes.
Cigarettes. Lift up over here. Push out against me. Push out. Your toes up with your hand. Down, massage it.
You're a very busy man in Murfreesboro.
Yeah. Does that bother you when I lift up?
Mm-mm.
How about here?
No, sir.
Okay. Let me have you sit forward. Any area that's particularly tender?
Mm-mm. No, sir.
And back here?
No, sir.
And here? No.
Mm-mm.
Okay. Well, you know, we had talked before about what I think it's going to take. All right, it's going to take opening up that space for the nerves for it to be better. And now, because you know, where your surgery was before, I mean, think that it's the same bottom disc space. It's collapsed down quite. It's breaking on down. And you have arthritis in those joints also.
Mm-hmm.
In order to really open up that space, we're going to have to remove enough of the joints that we're going to have to fuse those bones together.
Okay.
Right? So I think we went over a little bit what's involved with the surgery, but let me go over it with you.
Okay.
Yeah,
Yes, sir.
It'll be either 1 or 2 incisions, and it just depends on how solid the bone is when we get in there, put in the screws. All right, but it'll be either 1 or 2 incisions about this long of your lower back, over here and over here.
Okay.
All right. Even though your pain is on the left side, we may go in initially on the right side, and so you may end up with only 1 incision on the right side, but you may end up having another incision on the left. It just depends on how we put the screws and the cages in there.
Okay.
Right? But what we do is we operate through a tube. A tube is that's about this big around. Okay.
Mm-hmm.
Through the center part of that tube, we remove the majority of the joint, and then the bottom disc. All right, and then in place of the disc, we put in a titanium spacer to jack open that space a little bit.
Mm-hmm.
Over time, the bone will grow across that.
Okay.
And then we put a screw into the bone above and below that disc.
Mm-hmm.
And if we feel like the screws are your bone, and we're seeing it is not going to hold us well, we'll come in and we'll do it on the other side too.
Okay. Yes, sir.
And then we close the muscle up. The surgery typically takes up to about 4 hours or so.
Mm-hmm.
Most people spend on average 2-3 days in the hospital.
Okay.
We would want you wearing back brace after surgery.
Okay.
For the first, the back brace will limit how much bending you can do.
Mm-hmm.
We want you to restrict your lifting to 5 pounds that first month, and then 10 pounds the second and third month.
Okay. She's recording it so we can remember.
Yeah, that's fine.
Yes,
that's fine. After that, walking is the main exercise that we want you getting at the beginning.
Okay.
All right.
What about treadmill? Is that okay?
Yeah, it doesn't. Yes,
Okay.
that's fine.
Yes, sir.
Your goal is that by the end of a month after surgery, be able to walking 1 or 2 miles in a day's time.
Okay.
After 3 months, you're going to increase your lifting and your bending fairly rapidly.
Okay.
All right, as you can tolerate it. There are risks involved with a surgery. The number 1 risk is that it's not guaranteed to get rid of the pain.
Okay.
If you look at people who have this sort of surgery, roughly about 80% of the time people get good relief for their leg pain.
Mm-hmm.
It's about 70% of the time people get good relief for their back pain.
Okay.
The rest of the people are still usually better than where they were. It's just that they still have significant pain that's left in, right?
Yes,
and that's the biggest risk of the surgery.
Okay.
Other risks of the surgery are very small, but they're real. There's a risk of the anesthesia.
Mm-hmm.
You do have to be put asleep for the surgery. Rarely, but people can have reactions to medications. People have even died from being put to sleep. Obviously, that's incredibly rare.
Mm-hmm.
There's risk of infection anytime we cut through the skin. That's why we always give everybody antibiotics at the time of surgery to help prevent. There's risk of bleeding. If you had lots of bleeding and you had to have blood, there's risk with things like hepatitis and AIDS from blood. Chance of getting anything from blood these days is very small. Also, for this particular type of surgery, I have never had to give anybody blood.
Okay.
Risk of nerve injury with more numbness, more weakness. Chance of that happening is small the way we do this. There is a risk that the bone may not grow together well. If it doesn't grow together well and things loosen on up, in the future it could mean more surgery to lock it down to get it back.
Okay.
Happens rarely. There is a risk that we can tear the lining over the nerves and freeing it up and having what's called spinal fluid leak. Again, it happens rarely. If it did happen, it usually just means that you may have to spend a few days in bed. On an even rarer occasion, it could be another operation repair.
Okay. Yes, sir.
And then there's a risk that you can form blood clots in your legs, what we call DVTs. Anytime you're less active
Okay.
around time of surgery, you can form blood clots. Part of the reason why we get you up and walking day after surgery is to help prevent that.
Okay. Yes, sir.
The alternative to the surgery is to do what you've done in the past, doing the steroid injections
No.
and leaving this alone. And
Okay. That is not an option, Dr. Lynn. You know, if you're able to do the surgery, I want to take that.
Okay.
I want to go that route.
Okay.
Yes, sir.
All right.
Yes, sir.
Any questions about what I've been telling you?
No, sir.